All right, I'm going to. Thanks for inviting me here today. I'm very excited to talk to you about with you, the CSRAI community. I think there are lots of quite interesting collaboration opportunities here. But before I start, sorry. So before I start, I want to give you just a little bit of background about my research. So my goal is to improve health equity and access. And toward that specific goal, I developed digital health systems to address the needs of marginalized populations. And my background is in human-computer interaction, or HCI, with a specific focus on data-driven methods. And I also collaborate with folks from clinical and health science background. So here are a couple of our recent projects just to give you a broad overview of the types of work we are doing in our lab. I'm more than happy to talk about any of these projects after the talk. So in this project, we have been developing human-centered AI tools to support clinician training. So we are analyzing PTSD session data to understand clinical performance during these sessions. And this session data could include both audio and text, that is transcript, and we are trying to understand different attributes and characteristics of those sessions. And then we're going to use those assessment to provide feedback for clinician training. I'm also working on using generative AI for health interventions. So in this project, we are using generative AI for personalized and context-specific exercise interventions. We're integrating theoretical frameworks and demographic attributes like age, gender, as well as specific health needs to generate relevant and personalized messages. And some of those messages can be just text. Some of those could be multimedia, including images that would hopefully encourage others to engage in physical activities. In a different project, we have been using generative AI to create messages to support self-management in palliative care. So we are using symptom management guidelines and acceptance commitment therapy to create both empathetic and personalized message to support self-management in palliative care. We are also working with Shamsundar and Donna Fick from College of Nursing to develop a voice assistant to deliver customized and tailored cognitive stimulant therapy in dementia. My student Ishiao is working on this particular project. So I'm happy to discuss any of these projects after this talk, but for today, I'll focus on money, right? So how the recent advances in financial technology and open banking data provides a unique opportunity to transform mental health research and care. Now, mental health and financial instability has a cyclical and bidirectional relationship. So in other words, financial instability is associated with several mental health disorders. So impulsivity is one of the most common diagnostic criteria. Risk decision making is also associated with several mental health disorders. And these two factors, impulsivity and risk decision making, can lead to poor financial decision making and outcomes over time. For example, a study in the United States found that bankruptcy rate is 50% higher in bipolar disorder type 1 compared with the general population, which is an astonishing rate. To me, this seems like a sort of like a very surprising, astonishingly high risk for a given population. The presence of schizophrenia among gambling disorder patients is also 4 times higher than the general population. A study using population data from Sweden found that individuals with attention deficit and hyperactivity disorder, that is ADHD, have 6 times higher risk of defaulting. Now, mental health disorders are also associated with reduced financial capacity. For example, individuals with schizophrenia often have difficulty in performing and managing financial tasks. Depression has also been associated with reduced financial capacity for long-term financial planning. And reduced financial capacity is also an early sign of ADRD or Alzheimer's disease and related dementias. So a study using credit scores found that financial mismanagement patterns occur up to 6 years prior to actual diagnosis. Now, as I mentioned, the relationship between mental health and financial instability is bidirectional. That means it works the other way too. That is, financial strains and stress can impact mental health. There has been consistent findings regarding association between financial strain and depression. A recent study found that individuals living in poverty are more likely to be impacted by anxiety and depression. Multiple studies have also found that difficulty in debt repayment predicts onset of common mental health disorders. So overall, financial stability and mental health well-being are deeply intertwined. Financial activities can indicate mental health states. On the other hand, symptoms in mental health disorders might necessitate financial interventions and oversight. However, despite its importance, the relationship between money and mental health has remained difficult to characterize. And this is particularly due to the challenges of getting granular financial data. So prior work has mostly relied on retrospective self-reported measure or anonymous credit ratings. And now these data sets can be quite useful, but they don't provide a granular or complete picture of the relationship between mental health and financial instability. The resultant knowledge gaps have serious practical implications. So they limit our ability to develop a safety net for individuals with mental health disorders. Because to design effective interventions and risk mitigation strategies, we need to understand how the relationship between money and mental health change across different disorders from one individual to another, and also over time. Now, money is changing. How many of you have used cash this week? Right? How many of you have used Apple Wallet or Venmo this week? Right? So there has been a global rise of open banking and financial technology, or fintech. So open banking focuses on getting financial data out of institutional silos. That is, providing standardized access and API to enable consumers to securely share their financial data with third party. Venmo is an example of such a third party. There has also been a legislative push globally to enable open banking. For example, the United Kingdom, EU, the United States, and Brazil have recently initiated legal steps to enable open banking. And now around 73% of world interactions with bank take place through digital channels. There has also been a significant rise in fintech adoption since COVID-19. 9 in 10 Americans mentioned using fintech apps and services in 2021. This trend is true even for older adults. 7 out of 10 individuals older than 50 years use fintech in the United States. So here is the key takeaway. If you have one takeaway from this talk, let it be this one. Fintech can transform mental health research and service. And I strongly believe this community, that is the CSRI community, can play a strong role toward that specific goal. To convince you, I'll discuss our ongoing projects focusing on financial stability in bipolar disorder. So my goal here is to both establish the feasibility and acceptance. That is, what's feasible and what is acceptable when it comes to using financial data in the context of mental health care. So let's start with the feasibility of using financial data. So what financial data can we collect using open banking platforms? So we have just completed collecting financial data from 50 individuals with bipolar disorder in the United States. And this is an NIMH, National Institute of Mental Health R21 project. So let's talk about bipolar disorder and why we focused on bipolar disorder in this project specifically. So bipolar disorder is a chronic and serious mental illness. It is characterized by recurring mood episodes, that is depression, mania, or hypomania. Depression involves low melancholic mood states. On the other hand, mania is a period of elevated moods with heightened activity as well as impulsivity. So hypomania is similar to mania, but with less severe impairments. Now, BD can be characterized into distinct subtypes like type 1, type 2, cyclothymia, and so on. And the presence and the severity of mania, for example, differentiates type 1 from type 2. So there is no known cure for bipolar disorder. It requires lifelong management. And it is also a global public health issue. So bipolar disorder ranks as the 6th leading cause of disability globally, and it causes significant socioeconomic impacts. And financial instability is a critical concern in bipolar disorder. So as a matter of fact, risky or impulsive financial behavior is a diagnostic criterion of bipolar disorder. So manic episodes often are associated with compulsive spending. Depressive episodes are associated with reduced financial capacity. So in other words, financial instability is a key challenge in bipolar disorder. And that's why we have decided to focus on bipolar disorder specifically for this project. So this project collected financial and symptom data from 50 individuals with bipolar disorder. So we collected information about symptomatic periods using life chart method or LCM. So self-rating using LCM has been validated for bipolar disorder. And we use those rating as sort of a label for our analysis and sort of interpretation of data. We also collected data about decision-making and risk-taking behaviors using well-validated methods like delay discounting or Iowa gambling task. But let's talk about financial data collection specifically. So to collect financial data, we used Plaid, which is an open banking platform to collect structured financial data. Plaid supports data interaction with more than 11,000 financial institutes, including all major banks in the United States. It is used by several popular consumer-facing apps like Venmo, and more than 50% of the United States adults have interacted with the Plaid framework through these consumer-facing apps, frameworks, and platforms. And this is why we picked Plaid for our project, because it provides wide access to our potential population. So we developed a secure app using Plaid, and our participants would log into their financial institutes and give us one-time access. And we then collected their financial data for up to last 2 years. So our data set contains more than 67,000 transactions spanning 890 days from 50 individuals with bipolar disorder, so which is a quite sizable data set. So what information does a typical transaction data contain? So here is a subset of information contained in a given transaction. So you can see it provides quite detailed information about balance, category, and time. It can also include information about location and methods of purchase. And this information then can provide useful insights into financial behaviors and mental health states. So For example, if there is a rapid sequences of transactions or out of hours purchase, or even sudden shifts in spending categories, those can be potentially indicative of impulsive behaviors. Categories might also indicate risk-taking behaviors like investing or gambling. So what insights can this data provide? The data set that we have collected. So we have just started analyzing, so no concrete findings yet. But our initial exploration indicates some really interesting use cases and patterns. For example, this participant received a large sum of money, frankly, a life-changing amount, but then they ended up losing it within a very short period of time. So this plot here contains data from checking account only, so it is not the full story here. But nonetheless, this is a unique case of impulsivity and risky decision-making during mania that had a serious impact on their long-term financial stability. There was also a sharp increase in amount volatility, where volatility is calculated as a rolling standard deviation over 14 days. So you can see there is a huge peak in the middle of the manic stage. There are also multiple periods with transaction frequency spikes. I would like to draw your attention to the last two manic episodes. That is this one and this one. And the beginning of both of those manic episodes coincided with spikes in transaction frequency. Now, when we take a look at frequency and volatility together for this particular participant, it seems that these two metrics might indicate two different types of impulsivity and risk-taking behaviors. Because we don't see a sharp rise similar to the frequency there in amount volatility during the last two manic states. All right, let's take a look at a different individual. So for this individual, the account balance shows seesaw changes over time, though perhaps the changes are not as sharp as the previous participants' data that we saw. But there seems to be a higher volatility during the manic phase for this participant as well. And transaction frequency also seems to increase during the manic states. When we look into the transaction frequency over weekdays and weekends, the trend seems to continue. That is, frequency seems to be higher during the manic states for this participant. Now, compared to the other participant that we saw, the volatility and frequency change seem to be similar, like a consistent change over time for this participant. So what insights can this data potentially provide? So these are the research questions we are looking at. If you have any suggestions, please let me know. I'd love to chat. But our key aim is to identify personalized early warning signs. And towards that goal, we are interested in figuring out how does financial behavior change across different bipolar disorder stages? How does financial strain or fortune might impact illness trajectory? How is financial behavior associated with decision-making and risk-taking traits for a given individual? We're also planning to make the data public sometime next year. All right. So we talked about the feasibility of data collection, financial data collection. Now let's talk about feasibility of intervention design. We can use near real-time granular financial data to generate potentially 3 levels of interventions that reflect symptom severity in bipolar disorder. And these 3 levels could include behavioral monitoring and skill development, active behavioral intervention, and a transfer of financial control to others, perhaps at the height of their symptom intensity. We are currently planning a study with Jeff. Jeff is leading that study to explore different types of risk mitigating strategies and interventions focusing on financial stability in bipolar disorder. We're hoping to start data collection soon. But I wanted to show you some of the ideas, intervention ideas that we are exploring. For example, we are exploring, can we add friction to slow things down against impulsive shopping? For example, we can add some sort of attention check before one can make a purchase. We are also exploring cool-off periods where one needs to wait to complete a purchase, and that might also be useful in the context of preventing impulsive purchase. We can potentially also enable collaborative monitoring. For example, care partners can get notified when there are potential warning signs. So in this case, you can see a potential care partner is getting notified because there has been some anomalies or some sort of warning signs for a given individual. There is also potential for enabling data-driven collaborative management and budgeting. So in this case, two individuals, a care partner and perhaps an individual with bipolar disorder, are working together to collaboratively manage their their finances as well as their budgeting. Fintech can also support planning and advance directive to mitigate financial harm in bipolar disorder. For example, one can establish a plan for care partners to take over one's access to credit and bank accounts during symptomatic periods. So overall, this project shows the feasibility of collecting granular financial data. We have collected more than 67,000 transactions from 50 individuals with bipolar disorder. We are at the early analysis stage, but there seems to be quite interesting trends and patterns in our data set. And being able to access financial data also opens up unique opportunities for novel interventions, focusing on both self-management and collaborative support. Now, let's talk about acceptance. In other words, would individuals with bipolar disorder be okay with using their financial data for monitoring and intervention? And this is particularly important given financial data and mental health represent two highly sensitive domains, right? So to explore acceptance and potential concerns, we have conducted two survey studies. We collected data from 980 individuals living with bipolar disorder. In our first study, we collected data from 480 individuals living with bipolar disorder, and the survey used a vignette design following the contextual integrity or the CI framework. We picked this particular framework because it has been extensively used to assess privacy concerns. And this paper was published in CHI conference last year. So in our data set, participants are open to share financial data for long-term care management. They were specifically comfortable sharing all financial data types for their own review over time. But there were some demographic differences. For example, women were significantly less comfortable sharing financial data with their family, although they were highly comfortable sharing data with themselves. We don't know exactly what caused these preference differences between genders, but we speculate that women may perceive themselves at an elevated risk of financial exploitation. Financial data sharing preferences also varied across different bipolar disorder subtypes. So individuals with bipolar disorder type 2 were significantly more comfortable sharing financial data with themselves and their clinicians compared with individuals with type 1. Now, type 1 is associated with tendencies toward paranoia, which can potentially influence their sharing preferences as well as their privacy expectations for their financial data. So overall, individuals with bipolar disorder were generally open to share financial data, specifically for their self-management. However, there were some demographic differences in sharing preferences. Now, what about intervention? So let's talk about acceptance toward interventions using financial data. So in this second vignette study, we again followed the contextual integrity framework, and we collected data from 500 individuals with bipolar disorder. In our dataset, participants were most comfortable seeking third-party help with planning and budgeting, specifically from their care partners. And these ratings are consistent for care partners across symptomatic and stable states. Prior financial help-seeking behaviors were also associated with a significant increase in comfort rating across all third-party intervention actors. Now, this makes sense because individuals who had to seek out help before presumably will also be open to future support and interventions. This openness to interventions was exemplified by individuals with a bankruptcy experience. In our dataset, they are more comfortable with drastic measurements like 48 hours spending restrictions. Again, this makes sense because prior exposure to life-disrupting financial harms could make people more open to external or even drastic interventions. We also conducted an interview study to have a more in-depth look into both acceptance and potential concerns. So here are some selected quotes. P2 mentioned that, quote, "I think ideally you could use that kind of data, including the financial stuff, as an early warning system. Maybe a mood is changing so that you could get some help." So this shows potential openness to both financial and mood monitoring. P3 commented, quote, "When I start getting boxes from Amazon and I don't know what's in them, that's a sign I was a little manic that day. That's way too many boxes." And this quote shows the need to monitor both financial behaviors and trends over time. P21 also mentioned, quote, "I'm assuming using some kind of AI could detect my moods and give me advice on where I am mood-wise, because those are the times that things get out of control for me." And again, this code shows both the need and openness to use financial data as part of their long-term care management. Regarding spending prevention, P6 commented that, quote, "I'd probably be pissed at that time, but when the manic episode has come to an end or a near end, I'd probably be thankful," end quote. So this quote, for me, indicates both the challenge and openness for interventions. There were also some concerns about maintaining autonomy as well as privacy. For example, P5 mentioned, quote, I like to have my financial autonomy, so I wouldn't really like that for them to make decisions on me. I can see in what situations it would be necessary, but personally, I don't really like that." And our data clearly and repeatedly show the need to balance agency, autonomy, and harm reduction. There were also concerns about privacy. P12 suggested doing selective privacy-preserving data sharing. So, quote, "I feel like sharing something like a progress support would be more comfortable than sharing each transaction." So in other words, sharing abstracted view of data rather than sharing the full raw transactions with others. And I'd like to specifically draw your attention to a comment from P3, who is both a patient and a therapist. Quote, "I'm a social worker, I'm a mental health therapist, and I mean, I have looked for myself and my clients for any kind of financial tools for bipolar disorder, and there is nothing out there. So I think, personally and professionally, I definitely think it would be helpful." To me, this code clearly shows the need and openness to use financial data for long-term bipolar disorder management. So to summarize, our data from more than 1,000 individuals with bipolar disorder show the feasibility and acceptance of using financial data for long-term bipolar disorder management. Our preliminary analysis indicates potentially useful signal and intervention opportunities. Individuals with bipolar disorder were generally open to share their financial data, but sharing preferences might depend on demography, data granularity, and data recipients. So overall, there were some concerns about autonomy and privacy. So what's next? Now that we know this, what are the potential research or even implementation directions? So as our preliminary finding shows, there is both a need and opportunity to develop robust and privacy-preserving methods for financial behavior assessment. Specifically, can we develop personalized early warning signs? So in other words, how do financial behaviors and risk profiles change across different mental health disorders? For example, how does financial capacity and decision-making change between, say, bipolar disorder and ADHD? Also, how does cognitive decline potentially reflect in financial decision-making? Access to financial data can also help us better understand impulsivity and risk-taking behaviors. So as I mentioned earlier, impulsivity is one of the most common diagnostic criteria for mental health disorders. And risky decision-making is associated with several mental health disorders. However, our current understanding about impulsivity and risky decision-making is mostly from lab studies. And I think there is an opportunity to go beyond lab settings and into the real world. That is, can we use financial data to establish a transdiagnostic understanding of impulsivity and risk-taking behaviors in real-world contexts? For example, how does sleep deprivation might impact impulsivity in ADHD? How does that reflect in their day-to-day activities and decision-making? There is also an opportunity to design and develop data-driven interventions for self-management. Financial stability is critical for overall well-being and quality of life. So how should we design interventions to support financial self-management for individuals with mental health disorders? That is, what are the potential intervention components and design, and what components might work for whom and when, specifically what phases of symptomatic and recovery stages. There is also a need for designing interventions to support collaborative interaction and management. When you think about it, collaborative support is essential, specifically during symptomatic periods. For example, we can't ask an individual who is going through mania to sort out their financial decision-making. However, financial collaboration poses unique challenges because there is a stigma associated with it. There are potential for conflicts when it comes to collaborative management of finances. So future work should explore how to create data-driven interventions for effective collaborative support and management. So a key requirement here is to balance agency and risk mitigation. It is also critical to prevent financial exploitation, potentially by care partners. I also think there is a need to integrate financial stability as a key goal into current clinical care models. In other words, therapeutic interactions with clinicians should discuss money management and harm reduction strategies more. So we are currently working on financial partnership and assistance level, or FinTel framework, and this includes 3 phases: planning, intervention, and reevaluation. And these phases are reflective of the highly cyclical nature of bipolar disorder and mental disorder in general. So the planning phase are reflective of or focuses on establishing intervention strategies that would be necessary to sustain financial stability. The reevaluation phase, on the other hand, aims to support recovery during post-relapse states. And we believe these phases can be integrated into the existing collaborative model of care, which can lead to better financial stability for individuals with mental health disorders. Now, granular financial data also provides unprecedented potential for understanding how economic and monetary factors might shape health outcomes. So in other words, we can potentially collect financial interaction data over time from, say, high, medium, and low income countries. And that can help us to gain insight into social determinants of health. That is, how and when financial strains can lead to mental health issues. And are those factors consistent across, say, high, medium, and low income countries? Also, how does the relationship between money and mental health change over time, and how symptoms can impact financial risks and stability across different mental health disorders? There is also an opportunity to shape policy and governance. Current financial institutes inadequately serve individuals with mental health disabilities. So there is a need and also an opportunity to make both policy and legal changes. That is, how can we use the data to create more supportive financial institutes and technology? For example, can we create policies and guidelines to establish better debt protection, enable spending limit, as well as adaptive account control for marginalized communities? The key challenge here is to do harm reduction without causing discrimination. So there are lots of challenges, but also potentially impactful research and policy work to be done in this particular context. So I'd like to specifically acknowledge the unique opportunities for this community here. The intersection of financial data, AI, design, communication, and mental health has been understudied. So your expertise in privacy-preserving methods, algorithmic bias, design, and communication can help to reshape both fintech and supportive banking. For example, the CSRAI community can help to create both robust and privacy-preserving assessment methods. There is much to be done for temporal sequence modeling, anomaly detection, and transaction categorization in financial data. Furthermore, there is a need to ensure differential privacy methods for transaction summarization that can enable better sharing practices. Similarly, the CSRAI community can also play a strong role in developing data-driven interventions. For example, there is a need for generating contextual alerts from financial data. There is also opportunities in creating or designing effective frictions by creating personalized and context-aware spending prompts, as well as attention checks. Conversational AI, on the other hand, can also help with self-management support, collaborative planning and management, and advanced directive assistance. There is also a need for explainable AI to support decision-making for patients, care partners, and clinicians. The CSRAI community can also help with ensuring fintech fairness. So financial technologies certainly risk perpetuating or even amplifying existing inequities. So there is a need to prevent, for example, redlining of financial access for individuals living with mental health issues. We must also safeguard fintech access and outcomes against institutional power dynamic, specifically when it is between an individual and their insurers and employers. Also, what happens when fintech makes a mistake? Like, who is responsible for that error? What recourse individuals might have if they feel their context and usage have been incorrectly flagged? Also, how can we prevent financial exploitation by care partners? We also need to develop nuanced and adaptive consent frameworks. That is, how can we address the change in decision-making capacity across different mood states? For example, what prior consent and plan should be revocable during manic phase? So overall, I believe this community has unique expertise to tackle these challenges through interdisciplinary collaboration. We need frameworks that can ensure fintech is not just technically sophisticated, but fundamentally just, fair, and respectful of human dignity and autonomy. And I believe that this community has lots to offer here. And I hope this talk encourages some of you to take a look at some of these challenges. All right, I'm at the end of my presentation. To summarize, we talked about the feasibility of accessing granular data, as we have collected 67,000 transactions from individuals with bipolar disorder. There is general acceptance to use financial data for care management in our data set. However, there are some concerns about autonomy and privacy. I also discussed next steps and potential research direction, that is developing robust and privacy-preserving assessment methods, creating transdiagnostic understanding of impulsivity and risk-taking behaviors. We also talked about potential interventions for self-management and collaborative support. I also noted the unique opportunity here to use economic life course data to better understand health trajectory, as well as the opportunity and the challenges for shaping policy and governance. These are my very cool students and collaborators. Jeff has led lots of work here. There is also Manat there, who has been working together with us to figure out some of the analysis part, and he's working at being advised by Justin. And that's what I have for today. Thanks. I'm open to any questions. Sorry. Yeah, go ahead, please.